Presenting on behalf of Medicine 4. This is the case scenario of Mrs. R, a 26-year-old lady who's a housewife from Tiruvannamalai, presented with complaints of fever, vomiting since 1 week, abdominal distension since 5 days. She was apparently well until a week back when she developed fever, which is non-documented, intermittent, not associated with chill antipyretics. The vomiting was present since a week. Around 5 to 10 episodes per day. It was preceded by nausea, and immediately after food, non-bile stained or non-blood stained. The abdominal distension, present since 5 days, was associated with a mild right hypochondrium pain. It was a dull aching, non-radiating pain, and progressively worsened with abdominal distension and was associated with mild dyspnea. She also had yellowish discoloration of eyes. However, there was no itching. There was no bleeding manifestations. There's no history of oral ulcers, arthralgia, photosensitivity, no history of skin rash, no history of recent travel or outside food intake. There was no altered sensorium or altered sleep pattern. Past history-wise, she's nil comorbid, not had any previous hospitalization or surgery, and no alternative medicine intake. Personal history-wise, she had no significant loss of weight or appetite, no addictions, bowel and bladder habits were normal, mixed diet, and no significant family history. And on examination, she was conscious, cooperative, and oriented to time, place, and vital signs were normal. On general physical examination, pallor and icterus was present. There is no eschar or blanching rash. Per abdomen examination showed abdomen and the flanks were full. On palpation, there was epigastric tenderness, and shifting dullness was present on percussion. Respiratory system examination, there was normal vesicular breath sounds bilaterally, and there was reduced air entry in bilateral infra-axillary area with a stony dull note in bilateral infrascapular area, the left more than right. Other systemic examination were normal. So summarizing, a patient with 1 week history of fever, vomiting, and abdominal distension, and on examination, icterus. She had pleural effusion with ascites. So we considered our differentials. The first is an infective etiology, considering leptospirosis, enteric fever, dengue, malaria, scrub typhus. We also considered acute cholangitis and acute viral hepatitis. Immune-mediated autoimmune hepatitis was also one of our differentials, and acute Budd-Chiari syndrome was also considered as a differential. So we went ahead with evaluating the same. CBC, hemoglobin of 11.6, total count of 8,400, platelet count of 207,000, which showed a decreasing trend, but there was no bleeding manifestations, and urea was 12, creatinine was 0.57, urine routine showed bilirubin of 2+, and LFT, the total bilirubin at the time of presentation was 9.08, direct bilirubin was 7.63, with a total protein of 5.7 and albumin of 3.3. AST, ALT were elevated to 41 AST and 361 ALT with an alkaline phosphatase of 168. And over the next few days, there was a decreasing trend in the total bilirubin and in the AST and ALT level as well. And a week later, we followed up the patient. The total bilirubin came to 4.35 and direct bilirubin 4.03, AST ALT to 144 and 119. The PT-INR was also deranged, which again showed a declining trend as we repeated her investigations. And fibrinogen was 182. We considered infective etiology like dengue, malaria, leptospirosis, and we did the serology for the same, which was negative. Scrub typhus was also negative. Vidal was negative. Blood bone viral screen was negative. Blood cultures, 2 cultures were sent, which showed no microbial growth. Ascitic fluid analysis was done to rule out an underlying chronic liver disease, and which showed a WBC of 25 with lymphocyte of 42 and polys of 8. Albumin was 0.3, SAG of 2.5, high SAG, and a protein of 4.2, high protein. And there was culture sensitivity, showed no bacteria or with occasional pus cells. So after we completed the initial infective serology panel, we went ahead with IgM HAV, which was low positive um, on this at the time of admission.
Dr. Gladiss, you may have to wind up. So could you just explain?
And after a week, when we followed up the patient, the IgM HAV turned negative. IgG HAV was high and IgM HEV was also done, which is negative, and ANA was negative. Radiological examination, radiological investigation, chest X-ray showed left pleural effusion, ultrasound abdomen showed bilateral pleural effusion with moderate ascites. We did a carotid, we did a Doppler of color Doppler of the which did not show any thrombosis, ruling out a Budd-Chiari. So diagnosis of acute hepatitis A infection with ascites and pleural effusion, which is a rare combination, which is a rare complication of acute hepatitis A. So according to the national CDC, hepatitis A virus was responsible for 10 to 30% of acute viral cases and 5 to 15% of acute liver failure cases in India. And the attack rate was highest among the 15 to 24 years age group, mainly because of unsafe food handling or personal hygienic measures and contaminated food and water used in hotels and restaurants. And the source of infection was most commonly contaminated water supply and hotel drinks and water.
Dr. Gladiss, we may have to wind up.
And the pathogenesis was
Go to the
common for
management
both
of the patient. Last slide.
Okay, so ascites and pleural effusion in hepatitis A infection limited, and the common pathogenesis for these two complications in hepatitis A is intrahepatic sinusoidal hypertension is my take-home message.
Okay, fine. Thank you. Any question? One question?